Okay, in this lecture I'm going to go over some basic disease nomenclature, and it's a sort of disease nomenclature that you're going to find throughout your pathological basis of disease module or other pathology related module, and I'm going to cover some of the more common terminology that you're likely to come across. So in this session we're going to cover some key pathological terms, some of the more common pathological terms that you're likely to come across. We're going to look at the different cell types within tissue. We'll look at the nomenclature of those cell types within tissue, where that name comes from to help you to easily remember why things are called certain things. And we'll be relating the cell type of origin of certain pathological conditions and looking at where they come from within the tissue structure and why that pathological condition is called that particular name. So to start off, we'll look at atrophy. And atrophy is a term that's used where there is a decrease in the bulk of a particular tissue. That's often associated with death of a particular tissue, such as where you've got necrosis going on, or sometimes changes to cellular structure. So starting off with atrophy, you'll come across atrophy in many different disease situations, but atrophy is a decrease in tissue bulk, often as a result of cell death, or necrosis, or changes to cellular structure resulting in a reduction of that tissue bulk. So often found in muscle, and the opposite of atrophy is hypertrophy, where you've got an increase in each cell size and therefore an increase in tissue bulk. So atrophy can be due to inactivity, so if a muscle is not particularly exercised, then you'll get obviously a decrease in muscle bulk in that situation. And we find atrophy in many muscle wasting diseases. Now, in some muscle wasting diseases, you can have a combination of atrophy and scar tissue formation, which we'll call dystrophy. So, a disease like Duchenne muscular dystrophy, you've got both a loss of normal muscle and then a replacement of that normal muscle with some scar tissue. So that can actually end up with changes to muscular structure. We can see this disease here, spinal bulbar muscular atrophy. That's a hereditary muscle wasting disease, and you can see these normal muscle fibres here. Here's a normal muscle fibre, here is a very small muscle fibre. So we've got an overall loss of muscle bulk in this particular disorder. But just whenever you come across the word atrophy, also think about hypertrophy being the opposite of that. But then also think about dystrophy, where the muscle can be degraded. We get death of muscle fibres and then replacement of that muscle fibres with other tissue like scar tissue, which we call dystrophy. So next up is edema, and you'll come across edema in lots of disorders. Again, edema is the accumulation of fluid in the interstitial spaces between cells, and this is one example of lymphedema, or we also call it pitting edema, and that's because when you've got swelling of the tissue, you can press a couple of fingers into the tissue, remove the fingers, and that will leave these two pits as effectively the liquid is being pushed out of the tissue and then slowly comes back. And the sorts of things where you'll see edema is where you've got a circulatory problem, and that could be a vascular circulatory problem or a lymphatic circulatory problem. And remember, the lymphatics drain fluid away from tissues, so in this particular case we're dealing with something where the lymphatic system further up the leg has been blocked due to either a tumour or damage to the lymphatic vessels somehow, and that will cause an accumulation of fluid in the extremities. So inflammation is a very generic term to describe the accumulation of immune cells within the site of a tissue at the site of disease, and we typically have the suffix itis at the end of anything this is inflammatory. So conjunctivitis and dermatitis, and this is an example of dermatitis. So this is a hematoxylin and eosin stained skin section showing the different cell types within skin, and this is the very much outer layer of skin. These are keratinocytes. Down here we've got dermis and the subdermal fibroblasts, and within any tissue structure that involves epithelium, what we have is a separation of the epithelium, in this case keratinocytes, and we have a basement membrane separating the epithelial cells from all of the connective tissue below where we find the fibroblasts. and within those fibroblasts we find our blood vessels. So generally you don't see blood vessels in the epithelium apart from this here, but we are dealing with a disease process. So normally you don't get blood vessels in this epithelium. All the blood vessels are down here. Now on the hematoxylin and eosin stained section, you can see that the nuclei of cells are stained purple. Other structures, including these wavy collagen fibres, are stained pink, and other cellular structures are stained pink to give a nice contrast between the nucleus and the rest of the tissues. And the pink stained collagen is a typical thing that you'll see with connective tissue. Now what's also pointed out in here are these very small cells. It look like they've got very small nuclei. These are lymphocytes that have infiltrated into this inflammatory condition, and these very pink or deep red cells are the eosinophils, which are so named because they take up the eosin stain of hematoxylin and eosin very well and stain a very bright red, and that's classic also of an inflammatory condition. Okay, next up is ischemia and infarction, and these two terms are related to each other. Ischemia is a region of tissue which is lacking in oxygen, and we call that hypoxia, and that can result in cells undergoing cell stress and potentially cell death. You'll come across this term, things like transient ischemic attack, or also known as a mini stroke, where you get a temporary occlusion of a blood vessel, and then an area of brain that is fed by that blood vessel is transiently lacking in oxygen, and that can cause a temporary stroke, which then, when that vessel becomes unblocked, resolves. And hopefully, if that occurs quickly, there is no cell death in that area. You'll also come across this term where we have a blockage of an artery feeding cardiac muscle, and we call that ischemic heart disease. Now, infarction is the effect of a severe blockage of a blood vessel leading to severe hypoxia, resulting in cellular death because those tissues are no longer fed by that particular artery. And here we can see a brain which has had a catastrophic blood clot in an artery, resulting in this area of the brain completely dying and becoming what we call necrotic. We call this necrosis, or death of tissue. We'll also refer to it as necrotic tissue, and this is due to acute hypoxia. And we don't just see this in the brain, you see this in other tissues, and a myocardial infarction is where we've got blockage of a cardiac blood vessel, an artery, resulting in necrosis of some of that cardiac muscle tissue in a cardiac arrest. So those are some of the more commonly used major pathological terms. And what we're now going to move on to is looking at the nomenclature of cells and the different layers of cells within individual tissues. So I've already shown you some epithelium, and I've shown you some connective tissue, and I'm going to show you the nomenclature that we use to describe those. I've mentioned epithelium and connective tissue, but I also will talk about the mesenchyme being connective tissue. So we're going to look at how these cells get their names and an easy way to remember which cell types do what. So cell types undergo specialization very early on in embryogenesis, and this is a cartoon of a very early embryo showing the point where all of the major cell types have effectively been defined. So a cell that is here in yellow, the endoderm of the gut roof here, is always going to be defined as having a role of epithelium of internal organs, and we'll come on to why in a moment. Similarly, these cells in the middle of the mesoderm will always be connective tissue of some description in the adult tissues, but the cells which are our connective tissue come from this green mesoderm layer. All the different connective tissues come from this green layer, and similarly our non-neurolectoderm and our neurolectoderm come from here and here respectively. And this is, a few weeks post-fertilization, and once the embryo gets to this stage, the cells are effectively fixed into one of these 4 lineages, and they subsequently then specialise down different organ systems and different specialist connective tissue systems and so on. So the endoderm, which I've briefly mentioned here in yellow, is the epithelial lining of all of your respiratory tract, excluding the mouth and anus, liver, pancreas, bladder, all your major internal organs which have epithelium, so adrenal glands and everything like that, pancreas, all of that epithelium comes from this endoderm lining of cells here, and then they all then specialise down there, all their different routes. Endo is basically the inner layer of cells, whereas the mesoderm is the middle layer, and the mesoderm turns into your bone, circulatory system, all of your connective tissues, the fibroblasts that I mentioned earlier in that skin section, muscles, all of your reproductive system comes from that mesoderm layer of cells. And from that mesoderm we will get the term mesenchymal, and whenever you hear the term mesenchymal, think connective tissue. So mesenchymal stem cells are typically bone marrow stem cells that can produce connective tissues. Then we've got the ectoderm, the outer layer, and we've got the non-neural ectoderm and the neural ectoderm. And the non-neural ectoderm gives our outer layer of epidermis skin, just the very outer layer, the keratinocytes. We've got the epithelium of the mouth and nasal cavity coming from these cells as well. And then we've got the neuroectoderm, which results in the brain, spinal cord, a lot of the neuronal support cells, retina, autonomic nervous system, and the pigment cells within skin, the melanocytes. They come from the neuroectoderm. So these pigment cells are often very closely related in with neuronal cells. Now, cells of each of these lineages then come together to create mixed layers of tissues that create then an organ system. So in the skin that we've just looked at, we've got an outer layer of ectoderm, skin epidermis. Those are your keratinocytes. Then there's the dermis, connective tissue, sort of extracellular matrix, basement membrane layer. Then we've got below that the mesoderm, which is the connective tissue, the blood vessels and the fibroblasts, which are deeper down into the tissue, also fat cells. Okay, so now we're going to look at some tissues and look at the different cell types running through a particular tissue, and here we're dealing with normal human breast tissue. So the top image is the low power field, and this little square here is what is magnified down here. So we're going to look at all the different cell types, whether epithelium or mesenchymal, and see how they are arranged within the secretory epithelium system. Now, almost all of your secretory epithelium comes from the endoderm lineage. So think of all of your internal organs with secretory epithelium, pancreas and all of that, GI tract lining cells. A lot of those are secretory epithelium. Breast is a little bit different because breast is tissue is from skin and sort of specialised skin cells, in effect, sort of almost like specialist sebaceous gland derived cells. So this actually comes from the ectoderm lineage, and it's probably the only secretory epithelium you'll come across, apart from maybe some epithelium of the mouth, which is ectoderm lineage. But anyway, so most of the epithelium you're going to come across is endoderm. This is just a little bit of an outlier. However, the structure of the tissues is very much the same as many other glandular structures. So if we're focusing on this bottom diagram, we'll focus on the top diagram first. What you can see are these lobes and or ducts. These are little ducts or tubules of epithelial tissue which are secreting. The job is to secrete casein proteins down these little ducts, and all of these collecting ducts come together at the nipple, and that's a function of the breast for secretion of casein proteins for milk. So all of these circles of epithelium in dark purple are tubules which have been cut across when this tissue was sectioned on a microtome. And whenever you look at epithelium, you'll see that the epithelium always seems to stay darker than the connective tissue. And the reason why is that the epithelium is actually much more cell dense than the connective tissue. So if you draw a line sort of from here to here, you're passing through 1, 2, 3, 4, 5, 6, 7, 8 cells. If you draw a similar length line from here to here, you're passing through 2 or 3 cells. So this connective tissue here is much more cell sparse, and because the hematoxylin stains nuclei, we've got more nuclei per square micrometer here than we have here, so it looks darker and purple. So whenever you look at H&E, if you see blobs of purple in there, it generally means that's where you've got your epithelium. The pale pink stuff is generally your connective tissue, with a few odd examples. Sorry, few odd exceptions, I should say. Okay, so let's have a look at the epithelium here. We've got the arrowheads here. Now these arrowheads are what we call the basal epithelial cells, and they sit on a basement membrane that runs around about here, but we can't actually see it. So that basement membrane is extracellular matrix rich, so collagen rich, laminin rich membrane that separates your epithelium from your connective tissue. And the two generally do not mix unless there's a disease process going on. So these are your basal cells, they sit on the basement membrane. Then there's a second layer of epithelium, which are the secretory or luminal epithelial cells, and they line this lumen, and they secrete stuff into that lumen. And this is true for all, or almost all, glandular epithelium that you're going to come across. So there's your two different types of epithelium. This is where your basement membrane is. Then here we've got what we call, I would call these periductal fibroblasts. These cells line these, sort of surround these ducts. Some of them have some sort of contractile, smooth muscle-like activity that can actually contract these ducts and squeeze in a smooth muscle-like activity. These further out here probably don't. So these are periductal fibroblasts, these are just fibroblasts. And in between those are wavy ribbons of collagen that have stained pink with the eosin. The other key feature is this big arrow here showing a blood vessel lined with endothelial cells, and within that blood vessel you can see some red blood cells. So now we know the nomenclature of the cells. We know we've got epithelial cells, we've got fibroblasts which come from the mesenchyme. We know where the mesenchyme comes from. That comes from the mesoderm, whereas the epithelium comes from either the ectoderm or the endoderm. What we can now do is start looking at some tissues which are mixtures of epithelium and connective tissue and see different diseases that arise in either the epithelium or the connective tissue. And as a nice example, we'll start looking at prostate disease, because we've got two major diseases of the prostate, one caused by defective epithelium, prostate cancer, and that's derived from the endoderm epithelial cells, and these are epithelial cells which have become mutated and overgrown. And therapies aimed at this prostate cancer disease are aimed at the prostate epithelial cell growth and differentiation, which is androgen or testosterone driven. So we use an anti-androgen to treat this disease. In contrast, benign prostatic hyperplasia is an overgrowth of the fibromuscular stroma, which is the connective tissue, also known as the fibroblasts. Now I will use lots of words that describe effectively very similar cells. So I've mentioned periductal fibroblasts, they are fibroblasts. I've also mentioned fibroblasts, they are just fibroblasts. I've mentioned the fibromuscular stroma. Well, stroma is a sort of a collective term for all of that connective tissue around the epithelium that acts as a support for the epithelium. So benign prostatic hyperplasia is an overgrowth of the fibromuscular stroma, which is all of those periductal fibroblasts and general fibroblasts that you find outside of the epithelium. And these are also, I sometimes just call them stroma, because that's a perfectly reasonable word for it, and I will also call it mesenchyme. So mesenchyme and stroma is effectively the same thing, and then you can be more specific and say fibromuscular stroma, especially if it's got smooth muscle-like activity. You put in that fibromuscular term. Now, therapies directed towards benign prostatic hyperplasia often involve targeting this contractile activity of the fibromuscular stroma rather than the epithelium, because this is an overgrowth and overactivity of the fibromuscular stroma. So the drugs to treat benign prostatic hyperplasia treat these cells, the drugs to treat prostate cancer treat the epithelium. So let's have a quick look at some prostate epithelium, and it's not that not that different from breast epithelium. We have, here is the stroma in pink, this is quite a dark stained section, and here is the epithelium in purple. And these are ducts, and these epithelial cells secrete prostatic secretions which form a constituent of semen. So all of these are ducts which will all accumulate together and carry the prostatic secretions. This particular prostate is a young looking prostate because we've got nice big open ducts, and we've got quite thin ribbons of stroma or connective tissue running in between those ducts. So that's what we expect to see in a young prostate. In an old prostate, and benign prostatic hyperplasia tends to be a disease of older men, particularly those in the 60s and 70s. It's one of the most common diseases in elderly men. We've got big thick wedges of fibromuscular stroma and relatively little epithelium. And it's this stroma that increases in bulk, increases the size of the prostate, and the urethra runs through the prostate. So the symptom of this disease is the inability to urinate because of all of this bulk of fibromuscular stroma and also the contractility of that stroma bearing down on the urethra. So therapies for benign prostatic hyperplasia can be drugs that prevent this contractile activity, and also surgical means of boring a hole through the prostate, which is really quite unpleasant. Prostate cancer is an overgrowth of these epithelial cells, and the overgrowth to such an extent that they break out through the basement membrane and infiltrate into the underlying stroma. So this is a large tumour growing, and also within the stroma you can see that there are epithelial cells all the way through the stroma. They're not acting as ducts, they are infiltrating the stroma. And if you remember what I said earlier about the stroma, that's where the blood vessels are. And epithelium and blood vessels shouldn't mix unless it's a disease situation. And what can happen here is these epithelial cells can gain access to the blood supply and then metastasize or spread around the body. And it's usually metastatic spreading cancers that kill the patient rather than the tumours within the prostate or breast or wherever. So I've just been talking about BPH, benign prostatic hyperplasia, and prostate cancer, but I suppose I better tell you what is a tumour and give you some very basics of that. And a tumour, or tumour cells, are cells that have acquired a series of genetic changes which make them different to normal cells and that they no longer respond to normal cellular signalling. So within a single tumour, initially one single cell acquired a particular mutation, and then subsequently another mutation and another mutation that resulted in that cell having uncontrolled proliferation and inability to undergo cell death when it should do. And then subsequent daughter cells all carry these same mutations. Tumours can be benign or malignant. Lots of tumours are benign, that means they are non-cancerous. Some tumours are relatively harmless. And we use the term neoplasm and tumour, they're generally synonymous. So you'll hear the word neoplasm used instead of the word tumour. It's probably okay to do that, but neoplasm really means abnormal growth. Cancer is a very specific term, which is a malignant abnormal growth, and a benign tumour is a non-cancerous, non-spreading abnormal growth. So just to show the difference between benign and malignant tumours, and this is just a little sketch of how tumours form on skin, the difference between benign and malignant. And typically a benign tumour will form one of these vertical growth type tumours that form little nodules on the surface of the skin. So they grow effectively outwards, but they don't grow particularly deeply. And we'll call this is called a papilloma. If it's a tumour on skin, we'll refer to that as a papilloma. It's a benign tumour. The epithelium is restricted to a ball-like structure. There's an intact basement membrane. There are no blood vessels that have broken through that basement membrane, and this grows as a lump on the surface of the skin. In contrast, if it's a malignant skin tumour, and let's say something like a squamous cell carcinoma or a basal cell carcinoma, and the nomenclature of that will come shortly, in the skin we can have basal cells. We've already seen basal cells sitting on the basement membrane, and above that we have a specialist type of epithelium called squamous cells, which are what we call scaly-like. If they overgrow, they tend to create a lesion like this that grows downwards into the dermis and can access the vasculature. So this tumour here can't get through the basement membrane, it can't access the vasculature, it's effectively limited in how big it can get. This one can grow downwards into the dermis and access the blood supply, so this is what we call a malignant tumour. These tend not to grow upwards, they tend to sort of radiate outwards, and you sometimes get an ulcerated surface. Now there are lots of pathological conditions that result in abnormal excessive tissue growths, and there are lots of different names to describe these, and what we're going to go through are the different pathological terms for different types of growths and how they progress from sometimes they sound like they might be unpleasant and cancer related, and in many cases they are not. So this little series of names goes from increasingly likely to be associated with a cancer type situation. So firstly we've got hypertrophy. We've already seen atrophy, and I've mentioned hypertrophy. This is the increase in size of each cell resulting in tissue enlargement, and the sorts of things you would see there is cardiac hypertrophy, enlargement of the left ventricle of the heart, an enlarged heart, which is a condition that's where there is prone to catastrophic heart failure. But we'll call that cardiac hypertrophy. We can then move on to hyperplasia, which is basically an excessive proliferation of normal looking cells in the normal arrangement of cells for that particular tissue. So we've seen benign prostatic hyperplasia. It's an overgrowth of the stromal cells. They're in the correct arrangement. The epithelium cell still looks like epithelium. That's in its correct arrangement. And the stromal cells are in their correct arrangement. It's just that they are overgrowing, usually down to some local stimulus to make them overgrow. And we think in benign prostatic hyperplasia it's down to an altered ratio of estrogens and testosterone that is causing those fibroblasts to overgrow. But those are normal fibroblasts. Next term is metaplasia, and the definition of this is replacement of one type of mature type epithelial cell with another type of apparently normal mature cell. So in one of the most common metaplasias you'll come across is Barrett's metaplasia or Barrett's esophagus, and this is where you get acid reflux causing the normal squamous cells of the epithelium, which are more of a protective epithelium, they get replaced with columnar epithelium, which is more like the epithelium you see in your stomach, and that's a cause caused by acid reflux of stomach contents into the esophagus. So these columnar cells look normal, and they've replaced the squamous cells, but they're in the right tissue arrangement. They still sat on top of basal cells. Everything looks normal, it's just the wrong type of epithelium, so we call it a metaplasia. Getting a little bit more sinister is a dysplasia, and this is replacement of one type of mature cell type with a less mature, less differentiated cell type. So when cells progress from being a stem cell to be a fully mature cell, we call that process differentiation. And if a cell has failed to differentiate, that normally means that there's something genetically wrong with it, and it's failed to differentiate due to mutations that can subsequently lead to cancer. So dysplasia can be low grade or it can be high grade. Low grade will be something like an atypical mole. So a mole is hyperplasia of melanocytes, whereas a low grade mole, an atypical mole, those melanocytes have not only proliferated, they have also not fully differentiated. So this could be a precancerous lesion. Similarly, as we'll see on the next slide, early cervical changes after infection with human papillomavirus will be classed as low-grade dysplasia, and then a high-grade dysplasia is where the cells are still in the right arrangement, but they look really poorly differentiated. They look nothing like the mature cell type, and we'll see that on the next slide. Now, high-grade dysplasias can also be called carcinoma in situ in some certain circumstances, and carcinoma in situ, by definition, are very abnormal looking cells that are localized to the correct layer. So this is where carcinoma in situ overlaps with dysplasia. They show abnormal cell changes consistent with cancer, so you tend to have a much larger nucleus. We have prominent nucleoli within those nuclei, and that's a sign of a highly metabolically active cell type. And these cell types are often very hyperproliferative. So as cells normally go from being a stem cell to a differentiated cell, they go through a transit amplifying or hyperproliferative stage, and cells within the carcinoma in situ often are hyperproliferative. They're in that particular stage. And then we finally move on to cancer, and by definition that means locally invasive abnormal cells. And locally invasive means that they've moved out of their, let's say, epithelium and entered the mesenchyme. That is what we mean by locally invasive. If they can't do that, they are not cancer. So this slide shows all of those processes, or all of those named pathological terms, or most of them anyway. Here is cervix, a full tissue depth biopsy of the cervix. This looks very similar to skin as well. These are our squamous epithelial cells, look very similar to your skin epithelium. These cells here are the proliferative zone, so and we have stem cells within the basal layer. So a cell within the basal layer decides that it's going to start dividing. It goes to a round of rapid proliferation here. Then we get slowing down of growth, and then we get differentiation to these flattened squamous cells. Here's our basement membrane. Fibroblasts are here, blood vessels are here. These epithelial cells should never come in contact with that blood vessel. So a low-grade intraepithelial neoplasia, which is also a low-grade dysplasia. We see proliferation extending beyond this bottom third. So you can see plumes of cells rising up through the epithelium, through the normal squamous layers, and these are abnormal proliferative cells. But you see there is no breakdown of the basement membrane. Continuing on to high-grade intraepithelial neoplasia, I'd also call this a carcinoma in situ. You've got a mass of hyperproliferative cells. You see they're very dark, which means you've got a large nucleus, small cytoplasm. It's a classic sign of cells which are progressing towards cancer. Down here in the connective tissue there are no obvious plumes of cells down there, but there's some very dense looking cells there, but you can't see that they're actually linked to this. But the connective tissue also looks a little bit different to here. Really this is full thickness proliferative epithelium, and it's only a matter of time before these cells break through and enter the connective tissue, which has happened in invasive carcinoma. Invasive cancer, but carcinoma because it's epithelium, and the nomenclature is on the next couple of slides. So what's happened here is a disease situation like this. We've found some cells that have managed to break through the basement membrane, and then they grow vertically into the tissue downwards and access blood supply, and at this point this disease is potentially metastatic and could spread throughout the body. Okay, so we're going to get on to naming the tumours now, because I've just been talking about adenocarcinoma and we need to know where that comes from. Just to let you know, the tumours are classified by the cell type of origin before being concerned with whereabouts in the body they are. So the main cell types are epithelium, mesenchymal, hematopoietic, neuronal. Those are some of the major cell types giving rise to major tumour types. So as we've seen that the epithelium is either the upper or outer surface or the inner surface, depending if we're dealing with skin, outer surface, or some ductal structures, inner surface. So you think about your GI tract, secretory ducts, they are all epithelial cells. And what we find is that epithelial cells sort of behave quite similarly irrespective of which tumour they are from. They've got that classic arrangement of epithelium, basement membrane, and then mesenchyme. So we talk about epithelium as being one group of tumours, separate to mesenchymal tumours, also separate to the neuronal tumours and separate to the hematopoietic tumours. And as a result we have a naming system for all of these things, but I'm only going to burden you with epithelial and mesenchymal tumours. Okay, so we've got some pretty big words on here, but there's a simple way of remembering how to remember what tumour names are. So we've got epithelial tumours, which is 85% of all tumours, and they are named based upon what type of epithelial cell they originally come from. So we've got squamous cell, transitional cells, you find these in the bladder, basal cells, you find these in all tissues, and then you've got your glandular secretory epithelium. So breast is glandular epithelial, so is your GI tract, so is your prostate. Your skin is squamous epithelium, and so is your cervix. So cervix and skin, bladder mainly, basal cells throughout lots of different epithelial tissues, and then your glandular secretory epithelium from anything that is glandular. Now if those tumours are benign, we will, for most of them, we can just say it's a squamous cell, and benign, we've got papilloma. So we use papilloma, and where I showed you a benign tumour earlier where there was like a ball of cells on the skin, that is a papilloma. So squamous cell papilloma, transitional cell papilloma, basal cell papilloma, but then for glandular secretory epithelium we call it an adenoma. If these become cancerous, we just go squamous cell carcinoma, transitional cell carcinoma, basal cell carcinoma, and then we convert this into from adenoma, which is benign, to adenocarcinoma, which is malignant. So carcino relates to cancer. So if you see carcinoma, it's cancerous. So the main one to remember is adenoma is your benign glandular secretory, adenocarcinoma is your malignant, and then all the others you're putting the suffix papilloma or carcinoma on the end of the cell type. For mesenchymal tissues, well, you need to know the prefix and the suffix. So the prefix, adipose tissue, we'll call it a lipoma. So and if it's benign, it ends in oma. If it's malignant, it ends in sarcoma. So liposarcoma is malignant, lipoma is benign. Angioma, angiosarcoma. Osteoma, osteosarcoma. So this is benign growth of bone-forming cells. This is a malignant growth of bone-forming cells. The rhabdomyomas and the rhabdomyosarcomas, well, you just have to remember that these are the prefixes for these particular tissues. Similarly, chondrocytes, which are in cartilage, that's where the chondroma and chondrosarcoma comes from. So it's a good idea to just get your head around this table and remember the key terms, because the sorts of things we may do in your assessments is give you a scientific paper for you to read, which has got these pathological terms on it. And if I read a paper and it said, this paper is describing some observations in adenocarcinoma of the breast, I instantly know that that is glandular secretory epithelium and that that is cancerous. Whereas if I saw a scientific study on rhabdomyomas, I know that a rhabdomyoma is the benign form. It would be sarcoma if it was the malignant form, and I just know that striated muscle, that's the prefix that we use. So scientific studies, pathological studies don't always spell out what we are dealing with. You will see, transitional cell carcinoma. A paper on transitional cell carcinoma, you would have to know that is the transitional cells of, this is almost certainly the bladder or urinary system, and it's carcinoma, it is cancer. We're not dealing with a benign condition. And after a while, you get used to this language and you use these terms seamlessly within your assessments and when discussing these diseases. Okay, that's it from me. I hope it all makes sense. If not, drop me an email.